Y sin más, yo creo que damos la palabra a la primera ponente de la jornada, la primera invitada, que es la profesora Teresa Matina. Ya le conocéis, estuvo aquí inicialmente, es una experta reconocida en Europa en síndrome Jacobsen, es jefa de la unidad del Departamento de Genética Médica de la Universidad de Catania. Y nos va a hablar sobre una actualización, todo lo que ha pasado desde hace 2 años sobre el síndrome Jacobsen. Thank you.
Thank you, Sixto. Thank you, Jimena. Thank you, Cosme. And thank you to you all, families. I work in Catania, Italy. It's difficult. It's difficult everywhere because not much money is given to research and to genetics. These are my postgraduate students that have been involved in 11Q along the years. The last two are the ones that actually are working with me on 11Qs and other disease. And this is my colleague, is a biologist, Marco Fichera, who works with me in Catania. And this is Orsetta Zuffardi in Pavia. She's helped me, and she's still helping. I'm sorry, I will give you a similar speech as last year, 2 years ago, but progress are very slow, and they depend on the chances we have to collect information. So we go faster if you help us very much. And you are doing that. Shall I go on? Okay. So I want you to have a look of how chromosomes look on a slide after they have been arranged. And these are chromosomes 11. And chromosome 11 can be broken on terminal, as in Jacobsen, or in between, or there can be breaks in more than just chromosome 11, and maybe there is nothing lost, but there is a break, and the break could damage a gene. There are trisomies where chromosome 11, there is an additional part. And if we get all this information, we have a more complete information than just looking at Jacobsen. And this is my experience at this moment, 178 11Q children. The majority are Jacobsen. And some are interstitial deletions, but of these, a number are still Jacobsens because they show the same clinical and they have lost the same genes, part of the same genes. And we just do observational research. We collect information from you. And this is a support, we also support the diagnosis with genetics test and clinical management, and we can suggest how research can go further. We had to rub off from the group some children that didn't have 11Q problems. Some questions we can ask, and some questions we can answer. Ask dysmorphism, what is the phase, the aspects, malformations, what is abnormal functions, what is evolution, the prognosis of the disorder, if there are cancer risks, and what are the cause of death. And on genetics point of view, what are the breakpoints? If there are breakpoints that happen many times, what are the missing genes, what they do, if there are predisposing factors, and if there is a recurrence risk within the family. And follow-up is very important for us to update clinical information and for you to update the answers and update genetics information. We have gone through chromosomes and then through mapping with arrays, and we will go to genes after. I'm referring personal experience and review of the literature, but literature is described by different doctors who have different way of seeing patients and techniques for the diagnosis, especially in the past. And it is difficult to put cases together and compared. Publications also deal with the most peculiar case when there is something funny, not with the, let's say, regular 11q deletion cases, if you can say so. But my experience is a combination of cross-sectional observation, what I can do now in this conference, and I can see patients of different ages, and longitudinal studies, when I can see a child, a newborn, and see him in the following years, and see what happens, and see from the older ones what has happened in the past times. So during the conference, this conference, we can observe patients of different ages and try to figure out what the history of the condition is. But if I follow patients, I have more accurate information. And with the retrospective studies, collect information, what happened before, we can put together as much as information as possible. So we want consistent information and get information on knowledge and function of genes and give back the information to the family, 11q families for clinical management. But we also get information for general population because the genes that 11q patients are missing are also present in general population. And so to get this information is useful for everybody. So this is what we have from Jacobsen. It's been described first in 1973. The incidence is very low. There are about 200 cases reported. And the main features are dysmorphism, physical growth problems, mental disability, behavior issues, heart abnormalities, blood problems with the platelets, immunological problems, and other problems. In the family history, we know that some patients are both normal. They have normal chromosome, there is nothing wrong with them. Some patients have, the father or the mother has a translocation, and then there is a risk for recurrence. And some patients are born to a parent who has a fragile site, and which means that the 11q is breakable, is easy to break. And we got information about pregnancy. 2/3 are a term, 1/3 is preterm, and 2/3 are normal, apparently normal. The others, there are problems during pregnancy or delivery. And if you go to prenatal investigations, the screening, all screenings were normal in 92% of patients, ultrasound in 61%, amniocentesis was normal in 2/3 of cases. But now that you have arrays or non-invasive prenatal screening, the diagnosis in prenatal period is easier and is more accurate. What we see in 11q patients is a phase and psychomotor development, physical growth, other clinical features, and organ malformation. Why do we think the phenotype is important to study? Phenotype is the condition. If you had no abnormal phenotype, you had no condition. So if you could prevent any of these aspects, you would have a condition that is not so severe. So it's important to know what we can expect in a patient with Jacobsen and what can we treat or prevent. And some children have unexpected problems. This gives additional information and need additional attention. We know that children with 11q deletion are short. This is the number of patients. Most patients are short. Some patients are within the normal, and few patients are tall. And the head is small in few patients. It's mainly large or very large. So we have a disproportionate growth, and we must follow, see retrospectively, use specific growth curves for Jacobsen to see if they are normal as Jacobsen. We need to have dosage of growth hormone or other hormones. And with regard to the head, it's important to have image studies of brain and evaluation of children who had craniotomy. And it's important to get medical files to see if there have been complications and what the outcome is after surgery. These are the growth curves we have built. They are not complete as yet because we have not enough information from enough patients. Remember that patients have different breakpoints, and so we need to have a number of this information to get curves. But this is what we have now. And we want to know why stature is short. Stature is short in most chromosome disorders, but why the head is relatively large. This is unusual in chromosome disorder. And some have trigonocephaly, which is the triangular shape of the head. And some children would have surgery because of this, because the craniostenosis, the closure of the head, is too early, and the brain is not allowed to grow unless this bone is opened and let the brain grow. But we must know if there are complications that we expect with surgery. And, well, in 9% of children there are surgeries, and we see the complications are in about 1/4. And the outcome can be positive, or there can be relapse, and there can be problems. I think I've arranged with Sixto to have a database and collect all the information from you to know how many operations, what the clinical was during the operation, if there were problems, if there was need for blood, if there were positive outcome or relapse. And we want to have it as detailed as possible. So whenever there is a child who is going to be going through surgery, we can advise what the risks are and what the outcome would be, could be. And this would be quick and easy and very, very important. And it is very important if, when I send you the questionnaire that is filled in details, if you don't write down if you have done a test, I don't know if it is negative or is not just been done. So I can add the information only if I have fully completed questionnaires. We studied the face. The face with a number of items is incredible. And why do we need to have description of face? It's because it's useful to recognize children with the condition, but it also may help in understanding the expression of the disorder, because there is a great variability in the amount of signs that expression of the disorder in different children. This is for eyes. Peter Hammond has done the 3D analysis. I cannot go further. Oh. And you see the variability. These are children arranged according to the size of the deletion. And you can see that this child, this is an Italian child who has very small deletion, who has a face that shows the disorder. And there are children who have very large deletion, who show less in the face. And we want to know if what you see in the face is also similar in other expression, in other tissues, in other organs, in other... we know that some children are similar within the 11q deletion, others are not. And this is normal, 11q, and this is a 11q that doesn't fit with any. So we can use facial aspect for the diagnosis, to show abnormal growth patterns and to see if the degree of clinical manifestation are related also to facial aspects. And we have seen hands are like that, very similar in children, and toes are very similar in children. Most important is also to notice usually abnormal findings, abnormal platelets, trigonocephaly. And it is very unusual to have normal platelets. So if you have normal platelets, the case may be interesting to understand how it's possible to have normal platelets, as they are usually abnormal. And unusual pathological findings was the hands of one patient, very, very unusual, but may be related to the usual findings in 11q, just exaggeration of the same thing. And we have seen that the skin has problems. There are infections, there is eczema, warts, unusual scars, thick skin. We do not give treatment. I do not give treatment. But it will be interesting to collect information on children who have had treatment for any problem, constipation, treatment, surgical treatment for the head, or any treatment, and see what the result is after treatment. If we collect this information, we can give back this information to the families and say if it has been useful or not. What we expect in the neonatal period is problems. In 87% is jaundice, bleeding, respiratory problem, vomiting, feeding problems, low platelet, and heart defects. During the follow-up, we see spontaneous changes in the face. We follow physical growth. We follow variation in platelets amount, which becomes better, but not function. Function stays steady. We can see what happens after surgeries. We can see what happens to heart, vascular. I see in the more, in the adult, some scoliosis and obesity and skin problems. And we can check what clinical management has been and what the results, and we can check cancer risk and cause of death. This is very painful subject. But please, I need to be informed about children who have died, why, what happened, what is the reason. We must have a database of that. Genotype has given us the information of where the break is. We would like to know why, recognize clinical regions for chromosome critical regions on chromosomes for individual clinical features, function of genes or group of genes, influences of other genes, and the next generation sequencing will be very, very useful for that. And we have gone through traditional karyotype with FISH, array CGH, and next generation sequencing and expression studies will help to define more consistently genetics information. Traditional karyotype, FISH, you see how it looks. When you make array, you know if the patient has a balanced or unbalanced karyotype, but you don't know if there is a balanced translocation. So if you have a de novo abnormal array in a child, still there can be an abnormality, balanced abnormality in the parents, in one of the parents. But array gives us very detailed information on the breakpoint, and these are my patients, some of my patients. This child is my first 11q deletion child, and she had a very wide lesion, and the mother had a fragile site. This has been published a long time ago with these two other families. This was mine also. And this fragile site is a breakable region in 11q that gives very wide deletion. But what happens with a fragile site is that when the chromosome is broken at the fragile site, it happens as a necklace when it breaks. It doesn't just break, and that's it. It goes losing pieces. If you break a bracelet, you lose pearls. And this happens at a fragile site. So children with a fragile site, when the parent has a fragile site, children may have different degree of deletion, because before this break is healed with a telomere, there may be loss of a number of pieces of DNA. So you don't expect to have just one point. Even if there is a breakable region, the break will have a range of. So when we see these that look the same, they are not always the same. Maybe the same, maybe different. And however, with the same break, we have seen flat forehead, trigonocephaly. So there is a different expression, even within the same break. Same break, normal toes, big toes. So there are other genes interact with the deletion. And this is my Italian child with a very small deletion, but has the full 11q phase. She also had double ureters, double kidneys. And so this is one region that is likely to have all the genes that are needed to give 11q deletion Jacobsen syndrome. And then we have checked for individual aspects to see where the breakpoint is that is needed for a specific malformation. The skin shows xerosis, fine curly hair alopecia, hyperkeratosis, and this other abnormal. This aspect of warts has come out to be due to immunodeficiency. We must use the same criteria for clinical assessment in all children so that we can compare them. So we need clinical database. This is what I'm doing for the last 20 years, I think. The same updated techniques to analyze chromosome and cytogenetics database. It would be very nice to go on with the 3D analysis. And it's very important follow-up and update technology whenever needed. We need to complete growth curves. Immunological problems are being studied by the immunologists. We need to go on and study hormonal problems. We need to know why some children have scoliosis or other skeletal abnormalities. We need to have more information on MRI, skin, and outcome after surgeries and causes of death. We need to use new technologies, not only for genetics testing, but also for clinical phenotype studies. Understand the causes of rearrangements, map individual clinical aspect, understand variability is very important, improve clinical management. What we can do at the diagnosis at any age, because some children are not diagnosed until late, heart baseline evaluation, full cardiac studies, full neurological studies, abdominal ultrasound. If they are grown up, you don't need to exclude pyloric stenosis because it's in the neonatal period that you see it. But kidney and urinary tract malformation may not give any symptoms, may be silent. Ophthalmological examination, auditory test, blood test, hormone studies, X-rays, immunological assessment. Special assistance and treatment for congenital heart malformation, feeding, bleeding, and see if there is indication for early craniotomy. At follow-up, clinical evaluation, cardiac evaluation, ophthalmological, auditory tests, immunity, hormone. Each patient should have a complete checkup and then a follow-up that is tailored on the child. And keep in touch and update information and update technologies, both clinical and chromosomes. I finished my presentation. I want to thank everybody. I want to ask, I know it's boring to fill in a questionnaire, but this is the way we can get most information, the most useful from many children, and give it back. I am on Facebook. I am on Facebook because this was the way to know more, because you contact each other to ask, do you give something for constipation? Do you have problems with bleeding? If you give this information or ask this information in a more consistent way, in a more serious way, not just to a friend, but in a more organized way, we can give a more serious answer. Thank you.